Good morning, everyone. This is Community Conversations with HealthAdvocateX. I'm Robin Shapiro, the board chair. It's great to see you today. And as we begin this August the 8th community conversation, the topic this morning is going to be not only COVID, but also neurodiversity. We have a really special guest who we're going to bring up in a moment. But in the meantime, what I'd like to do is take a moment for our land acknowledgement in recognizing and offering respect to the original people in the land. And today I'm broadcasting from Qualicum Beach in beautiful BC. And so I really want to recognize the Coast Salish, Comox, Weway, and Cumland elders, past, present, and future, and for the original people and the lands that we are on, wherever you might be today. We also, our HealthAdvocateX board has a committee on inclusion, diversity, equity, and access. And as part of that effort with HealthAdvocateX, we will be establishing a safe place in all of our meetings. So I'd like to establish this meeting as a safe place today. And that means that every voice will be heard and respected. And just know that we enter this space with different lived experiences. And as such, we recognize the potential for unintended harm. And we are committed to healing should that harm occur. So consider this a safe space. You'll be hearing more about that as we continue our meetings. So with that, what I'd like to do is welcome both Dr. Dale Reisner. You've seen her weekly, monthly over the last couple of years talking about COVID, and we have a very special guest this morning, Dr. Malynnda Johnson, who's Associate Professor and Director of Graduate Studies for the Department of Communications at Indiana State University. Like we always do, Dale will first talk a little bit about the updated information about COVID-19, what you need to know, and then Dr. Johnson will be talking with us about neurodiversity today. So I hope you enjoy this. I'll be piping in, so if you have questions, just go ahead and throw it into the chat. And let's hear from these two wonderful human beings. Thank you so much, Dale and Malynnda.
Well, I will take off, and thanks for that introduction, Robin, as always. Such a great moderator. We are hoping to have a really robust discussion. Malynnda has a lot of really meaningful information to talk about diversity from a perspective on life for individuals. And we probably will all know someone who fits into the description of neurodiversity. It might even be you. So just a heads up for what Malynnda's going to talk about. I'm going to do a brief overview of where we are. I'm kind of getting tired of COVID. I'm sure you all are too. And so from the numbers perspective across the world, there are over 584 million reported cases. Remember, this is minimum because so many cases have gone under the radar. The death rate across the world is 6.4 million. Again, that is direct deaths, not indirect. We've talked about that before. In the United States, we've had over 92 million tested cases. And we're thinking that our ascertainment actually may be lower now than it was a year ago because of all the home testing that's happening. And there's over 1 million deaths in the US from SARS-CoV-2, from the varying different variants. Right now, BA.5 variant is predominant in the United States. There's another one of note that's out. I mean, that's like every few months we get that. We'll see what happens. The vaccination rate in the United States is actually quite promising for Ages 5 and above, one dose, at least one dose, 83.5%. So that's pretty cool because the kids are less well vaccinated. At this point in time, it's just taking a little bit longer for them to get access, and or if parents are hesitant. 71.5% ages 5 and above are fully vaccinated. So that is awesome. And about just under 50% have one or more booster. So from that perspective, we're doing quite well. There's a whole lot of data on vaccine effectiveness. What I want to do is report out on a couple of other things, and I'll just touch briefly on that. And then if people have questions about specifics, I can answer those at the end, because there's a huge spreadsheet of different subgroups for that. One of the things that I think people are talking about a lot is staying antigen positive for a longer period of time with the current variant, the BA.5. It's true. So if it feels like that's the case, it is true. Overall, about 54% of patients with the recent COVID variant are staying positive between 5 and 9 days. So, you know, that's just, it's not applicable really when you think about the CDC's recommendation for only quarantining for 5 days. If you are still antigen positive at between 5 and 9 days, the CDC is recommending you stay quarantined another 5 days. So I'm not sure that everyone is doing this. And I'm not sure that everyone is even testing. Some people are just staying quarantined for 10 or 11 days. Healthcare workers need to show negative tests, 2 negative tests before they come back. So that's kind of the approach we're taking. Oh, can't hear you, Roman.
Oh, is that universally true?
I do not know if that's universally true. That is in our Swedish system, and I think it's probably across Providence. I don't know if it's everywhere, but it doesn't pay for us to let healthcare workers come back if they're antigen positive, because then they're going to infect their colleagues. So that is the case there. Universal, because of the less expensive antigen tests that are available, our hospital system has gone to testing all admissions, and we are able to then see a little bit better sense of what things are doing in the community from asymptomatic as well as symptomatic patients. So there's still ongoing increase in infection rates. Across the country, there are death rates that are published. I think it may depend more on the vaccination status of those particular areas. Certainly in our area, we've not really seen a climb in deaths, but hospitalizations have increased a bit. This more recent variant also seems to be more asymptomatic than some of the others we had in the past. Very easily transmitted.
So, and why are we seeing more hospitalizations? Like, are the hospitals getting overwhelmed, or is it varied, or?
It's quite varied across the country. Some hospitals are definitely overwhelmed. Some ICUs are overwhelmed. In the Pacific Northwest, that's not as bad as it was in the past. So it really depends on the area of the country you're in as to what you'll be seeing. I think the fact that vaccinated people are getting sick, and also that people with comorbidities are needing to be admitted is really what's driving the hospital admissions. And like I said, I do have more specific data that if we have time for, I can talk about emergency room visits and things like that. With the high number of people that are fully vaccinated, although the booster rate is lower, the boosters really do help. And so we can talk about that a bit at the end as well. The other thing that I'm hearing questions about is Pexlovid Rebound. So the Rebound from Pexlovid, I'll give you a little bit of history. When it was first reviewed, there was a study that was done, a proper randomized controlled trial with some patients getting the Paxlovid and some getting placebo. So the rebound rate was 2% with Paxlovid, and the placebo group had a 1.5% rebound rate.
So same.
Yeah, almost the same, almost the same. There's a recent online published study that hasn't been fully peer reviewed. So, and I have not read it, but that is saying that maybe with the current version of the current variant, Paxlovid, it's more widely spread in its use than it was originally, of course. And people are seeing a 6% rebound. So that may be why you're seeing and hearing more about it. But what we don't know is the percentage of the non-treated with abbreviated symptoms transiently and then a rebound. So what I want to make really clear is this is not a reinfection. It's the same infection. It's not that Paxlovid is not working. It probably needs to be administered longer. When you're taking the Paxlovid, the symptoms go down and people do convert to antigen negative. What we think is there's some viral suppression and maybe not quite enough or not a long enough time. So you'll be seeing more in the news about this. And right now, you know, the decision for even taking Paxlovid really depends on age and comorbidities.
And can people be asking for more of it, or is that, how is that?
I don't think that's a thing right now,
Yeah.
but like I said, watch the news because I think that may be the case. And we don't know if you would have a rebound more. I mean, the disease tends to turn antigen negative on its own by about 10 days for most people. So I think that is something we'll see more about.
And do we have any data on whether or not that has an impact on long COVID or?
Yeah, and I didn't provide
sorry, I didn't think about
data.
That in prep.
Well, no, I did. No, I do know about that, and I've read about it, but I don't have anything I can quote.
Yeah.
That certainly vaccination, not Paxlovid necessarily, but vaccination and boosting does decrease risk of long COVID. So even if you get sick, if you have had full vaccination and boosting, you will be at lower risk for long COVID, but you won't be at zero risk.
Yeah.
And then I'll just mention the one area I was looking at for vaccinate just for COVID infection rates. Vaccination with the mRNA vaccines, so either the Moderna or the Pfizer, gives you almost a 69% decrease or prevention for infection if that is 14 days to a month since the last dose. Okay. If it's 2 to 4 months since the last dose, it drops a little bit down to 63%. But that's 2 doses and a booster, fully vaccinated plus boosted. So pretty good coverage from that. We don't have data yet about longer periods of time since your last boost. And I know lots of people are wondering about the younger people that didn't get a 4th booster, wondering about that. I'll just tell you that there is new information that the new boosters that are incorporating some of the Omicron variants into it will be out in early September is the proposed time, rather than later in September or October, which was the initial time frame. So that is in a few weeks.
So why is it earlier, and is there more of a risk if you boost earlier in terms of the gap between then and heading into the holidays? And
I think rather than opening up the last booster dose to more people, they put more time and money into getting the revised booster available.
Gotcha.
That is my best understanding of the circumstances. And that does make sense considering we're,
Yeah.
done with 1 week of August already. And so we're looking at a month away. Yeah.
Oh my gosh. Yeah.
I know. Time flies. So yeah, so I think I should stop there. I want to make sure Malynnda has plenty of time. If people want more details about Johnson & Johnson or about, not just infection, but hospitalization or ICU or whatever, we can drill down to that at the end if you'd like.
That's great. And so thanks, Dale. That was a very tidy presentation of what's happening. So thank you for that. And if you have any questions, just go ahead and throw it in the chat again, so we make sure that we cover it. And with that, let's go over to Dr. Malynnda Johnson. Welcome.
Oh, thank you so much for the invitation. I am both very nervous and very excited to talk about this with you because it's something that is very near and dear to the work that I have been doing. As mentioned, I am a communication professor at the University of, Indiana State University. I'm also the Associate Program Director for our Genetic Counseling Program. I'm on the board for PAC-B, and I'm also the chair of our Justice, Equity, and Diversity and Inclusion Committee. So doing work in diversity is what I do. My primary goal in the last 2 decades of doing research is focusing on exploring and engaging how people engage in difficult and or taboo topics, as well as giving voice to populations that don't often get heard from. A lot of my work has started with looking at the ways that various topics are represented in the media, including my second book that looked at neurodiversity and mental health representations in the media. And specifically, we were looking at ways that media is in a positive direction, helping raise awareness, have conversations. And it was great because we were writing this book and we were seeing all these great examples. And then the newest Joker movie came out and pushed everything right back. And like, we're writing all these great things, and then you do that.
So maybe for those of us who have not seen the most recent Joker movie, you could let us in on the joke because we don't know.
Not funny.
Okay.
There's
don't know.
Yeah, there's no joke. It
Okay.
goes back to all of the original tropes of if you have mental illness, you're violent, you're dangerous. It falls all the way back to let's use mental illness as a framework for showing destruction. And he's justified in doing the things that he does because he's had trauma and he's mentally unstable.
Got it.
No, stop making equations or connections between mental illness and violence. That's really damaging. So like I said, the work that I've been doing is really looking at how are we talking about these things. But now I'm doing a lot more so now that we know what these conversations are, we know who these individuals are and how they're being represented, what impact is that having on the ways that we are working with those patients, and how do we improve that communication? One of the areas that I am working with is neurodiversity. And before I get into like what those definitions are, one thing that to really kind of keep in mind is the fact that when we really kind of start off with the ways that the medical world defines things, it's pretty typical that we have, the normal and the abnormal. And anything that's abnormal needs to be fixed, needs to be corrected. They have a disability, they have something that's setting them apart. And there's tons of money and research for fixing things. And so when we are working with ADHD, autism, Tourette's, dyslexia, any ways that the brain is doing things differently for the longest time, and many argue still today, the focus is, well, let's fix that. Let's correct it. Let's prevent it. What can we do to make that not be a thing? But there's a large activism and a large group that I am very much a part of that is saying, no, and yes, we need to understand it more. And yes, if there are things that we can do to prevent, that would be great. However, we need a paradigm shift. Instead of looking at people that brains work differently, why don't we accept that they just work differently? And it's not that we need to fix them. Instead, we need to fix the environment and fix situations for them so that it's not that they have a disability, but they're in situations that are debilitating. So that's what neurodiversity is all about. The term neurodiversity kind of came out about in the 1990s by sociologist Judy Singer. She's kind of coined as being the one who came up with this. And it is really driven by primarily autism activists and saying, stop saying that there's something wrong with us. We just look at the world, relate to the world, connect to each other differently. It's not that it's bad. It's not that it's wrong. It's not that it's broken. We're just different. And that's okay. We should be able to live in a world just as happily as everybody else.
And
So,
how I love how this connects to advocacy in general and medical advocacy. And the reason why we're having you here today is we often say that advocacy is a communications job. And so giving us all language to explain what's happening with a client or a loved one's processing so that they can get the care that they deserve, I think is just so beautiful. So excited to hear some of your suggestions for that.
well, and I can use that, kind of as a segue in the fact that that's really what we're seeing is that we communicate differently. There is this idea of the double autism problem, which has been more recently studied and more recently examined. And what they were saying is that if you take a group of people, and let's just say we're going to play the telephone game, and this is what they did in Australia. You get a group of people, 100 people, 50 are autistic, 50 are neurotypical, and you have them play the telephone game. So I share a story to one person, that person tells and goes on and so forth and whatnot. And we know that always ends up in a hilarity and disaster because I bought a pepperoni pizza turns into I own a turquoise turtle, and it's nowhere even close to what it was supposed to be. But what they were discovering is that it was, just a gigantic mess when it was a mix. When you had autistic people talking to autistic people, the clarity and the connection between them and the completion of that chain was way higher than even neurotypical people. But they've noticed, and they're starting to really look at this, that when you have autistic people talking and communicating with each other, they're fine. There's no problems because they understand how they connect. And part of this,
so interesting.
One of the biggest traits of someone with autism commonly is that they don't have empathy. And that's false. Very much do have empathy, but the ways that they get to empathy is different. So for most people, we come to empathy with feelings and emotions. Like I was really afraid of this. I felt shame or embarrassment because this happened. And we come at it from that emotional connection. Someone who's autistic typically is not going to connect that way because they're very, very logical. An autistic brain is black and white. They do not understand. They do not think in gray. And again, this is in general because it is a spectrum. And so some are going to be better at that gray area than others. But typically it's black and white. So if you were to come to somebody and say, oh my gosh, I'm so embarrassed. I made this chicken dinner and I burned it. I lost track of time and I burned it. They're going to be like, okay, well, you should have taken better time. You should have set a timer. You should have done this. And that's going to come off as not empathetic. Have you approach it as, man, I lost track of time and I didn't set a timer and this is what happened. They're immediately going to be in that place of empathy with you. So when we think about this from a work perspective or a medical perspective, when we're sharing medical stories or experiences, if we're coming at it from that emotional place, they might not be able to have that same connection. But if we can come at it from a logical standpoint this is what the process is, this is what we need to do, they're going to connect with that a lot better, and they're going to be able to demonstrate that empathy because they think about it in more that linear process. So it really is important in thinking about understanding, and that's one of the biggest pieces of advocacy that I do, is if we can just simply understand that those brains are working differently, asking questions about how is it best to communicate with you, what approaches typically work for you in helping you process information. One of the biggest mistakes that people, and I've actually talked to a couple of my other autistic friends and their medical experiences, and so what would you say is the best advice? And two things came up, and one is never just ask at the end of a meeting if they have any questions, because they're typically going to say no. But if you ask questions about specific things, so tell me what you understand about this, then they have something very clear to talk about. The other thing was not giving a bunch of paperwork or worksheets and stuff at the end, but instead have that at the very beginning, and then use that as the guide point throughout. So they have time to process. Well, if you can give it to them ahead of time, process. But then also, as you're working through it, you've taken the time to really dissect and go through this black and white document and ask those questions then. So just understanding that those individuals are going to think about things a little bit differently. The use of eye contact, the use of other nonverbals, we expect that, that eye contact is going to be there. And a lot of autistic people that I know are really great about eye contact when they're listening to you talk. But the second they start talking, no, they want to look at everything else. They might meet you for a minute, but they're going to be looking all over the place. That's okay. Let them do that. Let them have that safe space. You might want to even say, especially if you're starting a relationship with someone, just kind of letting them know, like, hey, I noticed that, eye contact's a thing, or you can just ignore it and be like, yeah, no, that's not a problem. But don't take offense to it, right? Just accept that that is how they communicate. That's how we communicate. And it's perfectly okay. That's one of the, I feel like I say that's one of the biggest, because I feel it's also big, and when I'm working with my transgender populations and when I'm working with my neurodivergent populations, one of the biggest thing is don't focus on the fact that they're neurodivergent or that they're transgender or whatever. They're people. We're all people, right? That's our client. They have different personalities, just like everybody else does. We don't have to focus on that. The conversations don't always have to focus on, well, because you're neurodivergent, da 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 da. No, there might be some conversation about what traits they have and how you can best meet those traits where they are and create an environment that's going to be the most useful and beneficial. But the sooner we can accept those traits and just create environments that are supporting our clients in a way that supports them, the easier it's going to be. And the more supported that they're going to feel, because they're just being treated like everybody else. And that's what we all want to be treated.
So I'm curious too, for folks that are acting as advocates, is there any pre-discussion that should happen with the medical provider to set up a good framework, the most productive framework for an encounter?
I think the more that you know about your client and what their traits are and what they're looking for, and you can then kind of preemptively have that conversation with the medical provider so that they're not having to carry that load and that emotional labor, I think would be great, because they've already had this conversation with you. You can then advocate for them and say, can we make sure that, if we're able to think about sensory things that might be specifically challenging for the client. So when they come into an office visit, do they need to be sitting in with everybody else where there's lots of kids crying and lots of noise and it's bright? that could be really triggering. Is there another place that, I can sit with my client, or that they can sit when in the waiting room? But there might be just things that you can do to create an environment that's going to make them feel more comfortable. Again, encouraging how we're structuring that conversation, or structuring how often they're seeing, if that's going to be a chronic illness that we're seeing a doctor for, that keeping the same routine. And that might be just be working with the scheduler and saying, okay, so every Tuesday, or the first Tuesday of the month at this time, this patient needs to be seen, so that we can get that get that routine and help them understand, okay, this is what the process is going to be, because that's typically a big thing, is wanting that routine to help kind of get through situations.
Is there anything that advocates can be doing in first establishing a relationship with someone? Because I'm imagining that neurodiverse is a whole range, and that we all might be neurodiverse in some manner. So is there any appropriate language, tools, or accepted approach to be able to try to tease out, where there may be areas that an advocate can help someone navigating the healthcare system within whatever their area is that they're, that might be helpful?
I feel
Does that
like
make
there's
sense?
a lot there.
Yeah, sorry. I know it was overly vague, but
I'm like,
and
can you rephrase that?
yeah, and I guess what I'm saying is, so for some people, myself included, this whole neurodiversity language is a bit new in terms of understanding, like what is appropriate, especially when you're just starting a relationship with someone, to help identify how to help them best in language that is supportive and not inflammatory.
And I think actually, to add to that, what it would be helpful for advocates is how to, ahead of this encounter with a provider or someone, how to understand how you can't walk in their shoes, but how to get to where you can be most helpful and the language to use. And I think actually Vanessa put some terms in the chat that are helpful, but yeah.
Yeah, I was actually going to ask Vanessa if you don't mind. I do think that there's some really good points in here about, what accommodations, what benefits. Are there any additional thoughts that you'd like to add into the conversation? I would love your thoughts.
I have ADHD, so I have a million thoughts right now.
I understand that.
I am going to engage. By the way, I just so much love right now, you guys. When I saw this topic come up, I was like, I am going to be there. And just hello to all the advocates I know. Hi, everybody. It's Vanessa from Bannister. I want to just say one thing, and just Dr. Malynnda, love all of this. I think what you're doing is so good, because you're helping the helpers, right? All these people are like, tell me more how I can, if I'm not neurodivergent myself. It's almost like a glossary of, neurodivergent, non-neurotypical, talking about accommodations, the social versus the medical model of disability and neurodivergence. And I think what's nice for all the advocates out there is, I would invite you, and Dr. Malynnda, you could agree or disagree. It's totally fine. Again, ADHD, autism, we're kind of like, disagree, great. I love disagreement. It's fantastic. Like, not offended. But a lot of you guys already have deep experience in accommodations for other disabilities. And I really mean disability with pride. So, if you have someone who is unstable, and they don't use a walker, they don't use a cane, but you're going to already be thinking ahead, okay, as soon as we get in, I'm going to find the chair closest to the desk, so that when I'm having the conversation with the front desk staff on their behalf, they're not having to stand, because they've already used up all those, that energy and that strength just to get from the elevator to like this floor. So it's really like that same kind of program and just inserting new accommodations. And I added the language of, I would benefit from XYZ versus my son will benefit from accommodation XYZ. And it's all those details. Accommodations are not really in a different category than any type of difference or disability, or any time when there's a mismatch between the system that is being presented for you to navigate and what would be ideal, right? So think ramps versus stairs, think only right-handed scissors when you have a lefty, think glasses, think, right, all these different things. So I think if anyone in this call is feeling a bit like, oh gosh, is this a whole new world that I'm not familiar with? It might actually be a lot more familiar. And in the spirit of universal design, for those of you who are giant fans of universal design, some of the things that are going to be accommodations, you'll actually just start to integrate as best practices.
Yeah.
Good.
I thank you so much. Like,
Excellent.
Thank you. That was awesome. And you mentioned this idea of, a social model versus a medical model. And just in case there's anybody that's like, what do you mean by that? When we think of that medical model, it's you have a situation and a person with a disability. So I'm going to the mall and I am autistic and I have sensory overload. And so all of these things, but I'm in the mall and I'm the disability. Like the onus is on me. I'm the problem. And that's kind of that medical model. Like you have the situation and then you have this person who doesn't fit in, and how do we fix them so they can fit into the situation? As opposed to a social model that says we have an environment that is triggering a disability. So how do we change the system so that that person fits in better and we're meeting that person where they are? So to echo what Vanessa said, like if we know that there are certain things about our patients, our clients, that we can just create an environment that helps them, then we can do that. That's the best advocacy that we can do, is we just kind of think ahead and say, okay, yeah, you're going to need that chair. We're going to need the lights a little bit, like instead of having all the fluorescent lights on, can we just have on one? And as soon as I walk into that room, I'm going to turn those other two lights off. And part of this is, I like putting some of that onus on me as an advocate. Like, what are simple things that I can do that I don't have to rely on the provider to remember? And I don't have to like say, well, hey, we really need you to turn that light off. Maybe I just talk to them like, hey, when we come in, can I set the room? Like, will it bother you if I just turn off the lights? Or I move the chair? Or, whatever, I know I can create an environment that's going to be really helpful. If I can do that, then I'm not looking at my wonderful patient going, oh, they forgot to do this again, because that's going to be frustrating. But what can I do, or what conversations can I have to mitigate that and make it so it's not a disabling environment? So I can make that environment a lot more conducive to the way that they work. And some of that is asking questions, or maybe possibly interrupting a provider when they're explaining something and I know that they're going too fast, they're jumping all over the place, they're just skipping over things. I know that those things are probably not processing with my patient. So I'm probably going to either stop, and I'm just going to use Vanessa as the example because you're like highlighted in my grid. I might check in with her and just say, so, hey, what did you just hear? Like, let me circle back with you and make sure that, did that make sense? And hopefully by me saying that we've already built that rapport and that trust. And so that might help too, is if I'm asking the point of clarification questions and I'm checking if that's making sense, they trust me, and I might know it might even be a subtle tick that they, tilt their head just the slightest bit. And I know, yep, no, they didn't get that. So I might jump in and like, so one way to think about this is, and I translate what is being said from the provider to my patient, to my client, because I know how their brain is thinking and I know how to reframe that, emotional standpoint to that logical, or maybe they're in that gray area. And I said, well, kind of what we're saying here is it's this or this. And I take it to that place that they're going to be able to dissect a little bit better. And that's the communication of it, and being a competent communicator, being somebody who's an advocate, especially from a communication standpoint. We are storytellers, we are listeners, we are translators, and it's not just the verbal stuff, but knowing my client well enough that I know, like, they're kind of darting all over the place and they're not paying attention because they are flooded with information. And maybe we need to take a minute, and maybe we need to just give them a minute. I do a lot of work with domestic violence and sexual assault survivors. So those flooding moments and watching over and protecting my client and making sure that they've got a second to process what that provider just told them is vital to me. So that's like number one, is reading nonverbals. And while nonverbals with autistic and neurodiverse populations is different, they're still there. And a lot of people think, oh, well, they're just so bad at socialization and they're so bad at these things. I'm like, no, they just do it differently. It's not that it's not there, it's just different. And it's our job to understand what those differences are and go, oh, okay. So this is how that works. Other thoughts,
Can
questions?
I jump in, Malynnda? One metaphor that I love both to tell myself and then share with other people, and I already kind of brought it up. Remember a time in history when if you were left-handed in different cultures, there was like conversion therapy basically for being left-handed. They would tie your left hand back and they'd force you to write with your right hand. And now that is sort of considered like, wait, why would you do that to a child? Like that would be cruel. And that's an example of a difference having a value judgment applied. Different equals bad. Bad equals thing we need to fix. Thing we need to fix equals something we're going to force someone to fix before they even have a choice, right? And so we know how that story ends, right? In terms of all different kinds of difference. And I think what's really wonderful is that once you kind of go down a pathway, whether it's working with a client who has a disability, working with a client who has a condition like post-traumatic stress disorder, specifically related to medical trauma, so it gets triggered when they walk into a clinic or a hospital, aging clients, people who are in the fog of chemo, right? Literally picking one aspect of neurocognitive difference, which is working memory function. All of us, including only the people who have had a really fun night out the night before and wake up feeling kind of out of it. We've all experienced different highs and lows of working memory. And so I think that there's just extreme empathy, Malynnda and Grace, that I'm just like feeling as you're talking, which is again, what advocates kind of do. It's like advocate jam, that's their jam. I just want to say, if you feel at all like, oh gosh, this is unfamiliar, it's actually, I suspect it might be more familiar than you think, but this is what's good, is that learning the specificity to autism, ADHD, and really understanding, as you're curious, there's wealth of information online to understand, well, what are we actually talking about when someone with ADHD and an auditory processing disorder who might be experiencing medical trauma specific to a Swedish hospital, right? How can you be their sort of human version of a walking accommodation that can really make a huge difference for their healthcare experience and outcomes.
Thanks for sharing, Vanessa. And I want to just recognize Maggie Buckley, who has her hand up. Do you want to jump in here, Maggie?
Yeah, first off, thank you, Malynnda. Thank you for incorporating ASL into your presentation, whether you realize it or not. Some of us, I'm not fluent, but I know enough. Yay! And I'm also one of those, I am 60 years old. And so as a child in kindergarten and first grade, when I was learning to write, the pencil was moved from one hand to the other. And I can tell you from that experience and research that has come up since then, it's been demonstrated that doing that, children develop stutters amongst a whole bunch of other neurocognitive differences in there, which is, you mentioned that Vanessa, and it was like, oh yeah, it's like a flash from my past of everything. And I'm just back from a week-long conference of people with a chronic health condition that it's Ehlers-Danlos syndrome and hypermobility spectrum disorder. And so we had 300 people in person and 1,000 people around the world virtually participating. And for the 300 people participating in person, we had daily reminders for them about how to behave, basically, or how to function, or how to access materials. Likewise, appropriate messages were going out virtually. Because in that population, I am getting to a point and a question. In that population, there was research presented at this conference that somewhere between 50 and 80% of people with this chronic health diagnosis have a neurocognitive difference. And so my question is for Malynnda, are you seeing more research recognizing that people with chronic health conditions of all ages are finally having their neurodiversity recognized?
Yep. Yeah, and that's really great news. The thing with ADHD and autism and some of these other neurodiverse things is that so many people don't get diagnosed until later in life, because oftentimes they're looking at other conditions that are related to it. For instance, gut health is a huge thing in the autism population. And so you're going to the doctor because of all these gut issues, and they're focusing on these things, and they're not noticing that, wait, that is incredibly, incredibly popular and a well-established connection with these other things.
Maybe not popular, but seen
Well,
widely.
Yeah, seen widely, that's the better phrasing of it. We're not hoping for it.
Well, yeah, there's the gut issues, the hypermobility, a whole bunch of other things in that list, right?
Yeah. But I think there's starting to be, because we're recognizing that, and there is far more of a conversation about late diagnoses. I think and I'm hoping that as patient advocates, as we're starting to hear some of these things, we can kind of make that connection and have that conversation with the doctor and say, hey, have we ever thought about this also being something that we need to take into consideration? I recently was talking with a friend of mine, and he was going through some of these experiences, and I've known him well enough. And I brought it up to him. I said, have you ever had a conversation with your doctor about this? He's like, well, I was tested as a kid, blah, blah, blah. I'm like, okay, well, but we know a lot more now. You're 65. We know a ton more now. Maybe we need to have another conversation with your doctor. And if you need me to go with you, I'm happy to do that. And he eventually did. And the doctor said, oh, yeah, without question. I thought you knew that. Okay, so now that we know that, how do we, proceed? And are there other things that we need to be thinking about and taking into consideration? His doctor cracked me up. My jaw nearly hit the floor. He's like, well, yeah, I just thought you knew that. Where?
So funny.
Where
Yeah.
has this been documented that you've had this conversation? They're so special.
So, and our medical professionals, and maybe this is a question for Dale as well, I don't know, are medical professionals hesitant to document neurodiversity in the medical chart for fear that, I don't know, if people see it, they're not going to be appreciative of that, or how does that go?
I don't think, first of all, I'm sure Malynnda would agree, and everybody else on here, this is a burgeoning field of knowledge, investigation, how to approach so many things that really fit the story of the person who's 60 years old and you're pretty sure that they have at least ADHD or some variant, and they were never diagnosed with that. So yeah, and I actually have 2 adult children, one who was pretty obvious through school, had a learning disability, has been tested twice, and the first time was borderline, and as an adult test positive for ADHD with formal testing. But if you don't do formal testing, there's a couple of problems, right? So labeling is a problem. And what I think is really the issue is using, and we haven't talked about this or presented on this, but it's so exactly what Malynnda's been talking about, and also some of the suggestions that Vanessa's made, is trauma-informed care, no matter who we're taking care of. That we recognize that everybody's been through something somewhere along the line, some of it pretty dramatic, some of it less so. And it may be, the left-handed, that's childhood trauma. I mean, I don't know how you can explain that in any other way. Trying the conversion therapy that some places are doing for people who feel that they're not traditionally heterosexual, right? Whether it's trans or whether it's gay or you name it. The things that happen that we humans do to each other, because we're not treating each other as humans primarily, as individuals primarily. So if we could get that fixed, we would have a huge impact on the displacement that people who are a little bit different than that. What I don't even know what the average is, right? Like, what's the average? It's people who fit into the old-fashioned educational system and didn't fall out. It's people who, behave themselves in a certain way. And I think that idea of individual uniqueness needs to be highlighted more than anything else as we move through changes in healthcare and changes in healthcare advocacy. And that would improve the interactions that Black, African American, Native American, hearing impaired, however you want to call that, right? That's always the deaf population, the sight population, on and on and on. Who doesn't have something that's unique about them? And how do we adjust to our interactions to appreciate them for who they are? I think that's really what it boils down to. And it's going to take the medical community a long time to figure that out. There are some places that are working really hard on that. An example, because I like to bring out the race ethnicity piece, is we have at Swedish, we have a grant for that's called Just Birth, for reaching out into the community and training African American and Native American doulas, so that the support person can look like the person who's coming in for labor and delivery. And the same sort of thing is like, that doesn't mean that those of us that have white faces on this screen, that people I'm seeing on the screen mostly have white faces, can't be advocates. But we have to start with, this is a person who has value and may have a different way. Whoop, yay!
Hey!
Hi, Barbara. It was getting a little scary here.
And
yes.
you can't really tell, but I am Hispanic. So
No, exactly. And so that's the thing about the neurodiversity as well. So I was telling you, I have two kids that have ADHD. The one was obvious, he was struggling with school and he had, peer interaction stuff. It was pretty obvious. He still was pretty high performing, has a very high IQ, pretty high performing. The other one was just recently diagnosed in her 30s, so if you look like something, people, for good or bad, categorize you as something and may actually treat you better, maybe not, may not treat you correctly. But when you are polished, like Miss Vanessa, I don't think that people would appreciate. So we just have to take each other at the fact that we're each a human and we have backgrounds that no one else understands, that your perceptions of life are different even than your siblings growing up in the same family, right? and that we need to be kind to each other. And I think I'll stop talking there, but it just brought out exactly that, it's not just healthcare, it's how we interact with everybody everywhere. Justice system, going to the grocery store, you name it. Just be kind.
And can I jump in real quick?
Yeah.
Again, I just before, yes. The only thing I want to add to get back to Robin's question about, putting this in charts and things is, as I mentioned before, this is a paradigm conversation, because there are still many, many providers that when they see ADHD, when they see autism, their brains go, how do we fix this? So they're not even thinking about advocating and making, environmental changes and things like that. Their only thought is the traditional paradigm of, you are broken, so I must fix you.
Right.
And so as advocates, I think one of the biggest things that we have to do is I really want everybody to have this charge of pushing this paradigm forward and helping more people just in general think about how we move to that social model. This is very much an invisible illness. We don't treat people on crutches, the same way that we treat people that are deaf or have any type of mental illness or any type of, if it's invisible, they're treated in a completely different category. And as somebody who has multiple invisible illnesses, and I'm polished and, I have credentials and things like that, so just people assume things. It's really interesting to see how people talk about things. Then you're like, hi, I'm of those people. Let's learn to do a little bit better. But just recognizing that when it comes to this, there's still very far work to do in terms of getting this paradigm shift and rethinking the ways that we are accepting neurodiversity as just a different brain type. Brains work a little bit differently.
And as we're wrapping up, Seema has her hand up. So Seema, jump in there.
A couple things. One is that I think that the ingrained expectation to think of neurodivergence as an illness or something that's wrong that needs to be fixed is just, I'm hearing it in like snippets of what people have said in this conversation. And I think, it's not something that we should even, every time we think of it as an illness or something to fix, like, oops, I screwed up that time. In terms of it being in the medical record, I feel like, I think no sensible health practitioner would put a diagnosis in the medical record that is not verified. You might put rule out whatever, we'll evaluate for this, because it just like gets you in all sorts of legal and other kinds of trouble. But once someone has a diagnosis, I think it should be put in the record, and often is, and hiding it is not going to fix the system. It's like the more you have it out there, just like I want to know if someone is right-handed, well, not in my specialty, but anyway, whatever. It's like, oh, there's all these pieces that help me understand who the person is. And I think the less we hide it, the more we normalize it. And interestingly, I was just reading something, I think it was one of the advice columns in the paper this morning, and someone saying, what do I say about just the parents of someone who committed suicide? And being a suicide survivor, which doesn't mean I survived suicide, it means a family member committed suicide and I survived. it's like, we're just all committed to talking about it. Like, we're not hiding this. The more we talk about it, the more we show that, you know, we want to talk about the person. We don't want to hide it.
Thank you.
You know, it's not, you know, it's not the same exactly, but it's like all this stuff, like, don't hide it. We want to know
Yeah.
about it.
Yeah, thank you. Thank you, Dr. Khan. And she got the last word in. We're right at time. And I just want to thank Dale and Malynnda for sharing their wisdom, and for all of you for tuning in, and also for your insightful questions and awesome resources. So if anybody wants a saved chat from today, and you need to and you can't access it just from Save Chat, just go ahead and send an email and we can send it back to you at info@healthadvocatex.org. Thanks so much. And we'll see you next month. Bye, everybody.
Thank you, everybody.
Thank you so much, Malynnda.
Yeah, thanks, Malynnda.
You're so welcome.
Bye,
Bye-bye.
Malynnda.